Good afternoon, everyone, and welcome to SAS 5P04's Transdisciplinary Seminar. My name is Samantha Witkowski, and I am a first-year master's candidate in the sustainability program here at Brock, and I will be facilitating today's seminar. So today we have two presenters who will be discussing health, healthcare, and the environment, and how these are all connected. Our first presenter is Dr. Anna Sanchez. She is a professor here at Brock University and the chair of the Health Sciences Department at Brock. Her research primarily focuses on tropical parasitic diseases and global health. And because these illnesses often disproportionately affect low and middle income populations, she's also interested in building capacity and research proficiency in areas such as Honduras. So today she's going to be lending her expertise to us in her in the health field to discuss the connections between our environment and human health. So please welcome Dr. Sanchez.
I commend you for your good memory and remembering the big words: tropical parasites, global health, research capacity strengthening. That's all what I do. But most importantly, I'm interested in health, and particularly health of children. Although narrowing it down to just children, it's not possible, because then we have to look at everything in all of the intersections of that child's health since the womb. So thank you for the invitation, and I am the opening act for Victoria. So this is like a concert, and I'm like opening for her because
put me on the spot.
Yeah, well, what I have to say you probably already heard, but what she has to say, I was like, really? So I'm very interested in what she has to tell us. And mine was like, I already know that, right? So, but then Ryan said to us, okay, you guys work together, right? And we're like, okay, I work here, you work there, and this is why. So truly transdisciplinary moments that we had, and talk how can we intersect with what each other does. So I fight the environment that is being sickened by us. So this is my premise. We ruined and polluted our environment. It wasn't like that before, but now it's making us sick. So we're blaming the environment for a myriad of infectious diseases that are transmitted through soil, through water, dust, and we cannot but blame how filthy and how dirty the environment is, and pigs and dogs roaming around. Well, whose fault is all this, right? So we're like, we think we need to start working upstream as to stop working and ruining the environment. So that is the premise where I'm coming from. But just to set you on the mindset of where we're coming from with this environment, I am of a generation that was raised thinking that there were two types of resources. That's all I am: renewable and non-renewable. And they told us water, forests, they renew themselves. You can cut down all of the mahogany trees in Honduras, take the best genetic specimens to Europe, build the beautiful furniture of mansions, and they will build themselves back, right? So we gave companies 100-year contracts to exploit mahogany, to banana plantations, monocultures, and we thought, it'll be okay, right? We started depleting the rivers, and my dad was a truck driver, and he used to go to the riverbeds to extract gravel and stones. Well, he's one of the culprits of those rivers being completely empty now, because of all of the riverbeds disappeared, and then the flooding. So yes, a tropical country that has been ruined by us, and the environment is no longer tropical, it's really arid. So we thought we can freely consume, and some religions told us that we are at the top of the species, and they're like, oh yeah, so we dominate everything, we can name everything, we can do whatever we want. That wasn't a great idea either, because we thought that we owned the planet instead of being shareholders and one of the species that is not even the most important biologically speaking. And if we disappeared, I cannot help but think that everything would be green again. So maybe not such a big deal if we disappear altogether. So we could, I mean, not now, but eventually, as a species, it will reset itself, right? You watch Galactica, for sure. So this resource constraint and extraction and more, we need more. We also produce waste, and what is this waste going? We have one planet. So this results in our demise, and this is exactly what we're experiencing right now. Overpopulation, crowding, filth, open defecation. So let me introduce you my friend. This is the poop emoji. And when I teach, a lot of students feel uncomfortable when we say the word. So I just say the poop emoji. So you'll be seeing the poop emoji a few times. But India, for example, is one of those places where open defecation is so insane that the amount of pollution in the environment is appalling. And you'll see why that is a problem. It's not just like ew, no, it's beyond ew. It's beyond the ick factor. Our own man, Josh here, he's from Grimsby. He just painted, I don't know if you're familiar with his work. He's a gifted child of Grimsby and, Stony Creek. And he just painted this, it's called Occidental Babylon. And if you read the description of Occidental Babylon, and it's the same, right? We went, the gold rush, we extracted, and then we left in ruins, and everything else, fell down. So check his work. It's really amazing. It's like realism, but with a fantasy. I don't recall the name of the technique, but he is truly a gifted child. So he's like 22, and he already has a book of his life. I'm like, your life, you're 22. So we have this reading. I don't know if you had time to check it out, but it's about WASH, the water, sanitation, and hygiene, and environmental anthropathy. And that is a concept where it just blows your mind. You're like, really? So all of this filth, what is it doing to people that live in that filth, in that gross environment, that have no other choice but to breathe and touch and come in contact with this? So this is important because water, as you know, safe water, a clean environment, a healthy environment, and hygiene integrated into behavior. But behavior is we're not even ready for behavior, right? We think about behavior as like people should know how to wash their hands and should know do this, do that. Yeah, you should just use protection so that you don't get chlamydia either, right? And we know that chlamydia is one of the highest, rates in Niagara. So do we know how to avoid? Yes. So then it's not just really education and behavior, it's something else, some barriers. Even the vision of the world and our own life. So I'll be back to this later. But why do I wanted to talk about the environment and how it's making us sick before it was great and it was actually working for us? It's because we have promoted these immense disparities of wealth. 26 people have the wealth of half of the world population according to the latest news. So they could be in this room, and they would be the half of the richest people in the world, right? So that is crazy. Disparities, countries report national budgets that are an average of those that have a lot with the averages that they have nothing. So think about Carlos Slim in Mexico or Bill Gates in the US, and how that averages your income. And then you turn out to be in a rich country. So because we've done that, the environment has become an expression of the circumstances of the people live in. So the environment is just reflecting our state, collective state of neglect and despair. And the environment then is depleted, is infected, is infested, and is conducive to the many neglected tropical diseases that exist, that are a synonym of poverty and a synonym of not neglected diseases, but neglected people. 1 in 3 people on this planet live at risk of acquiring any of these infections, but 1 in 6 is already infected. So say 7-point-something billion population divided by 6, this is the number of people that are infected with one of these entities. And big pharmaceuticals haven't been interested in creating new treatments. The diagnostic companies haven't been interested in devising new diagnostics. The same governments where these people live haven't been interested in them because they're politically invisible. They're the poorest of the poor. They have no political value, and I aided to that, the corruption that exists in many places. So nobody really cares about them, save a few medical missions that go to those countries and try and give, a Band-Aid aid of, okay, here, a bag of Tylenol, just in case you get a headache later. That doesn't really help either, but that is what they have. So there are some worms that affect our children, and when I say our children, I come from a country where probably more than half of the children are infected with parasites. More than half of the children have head lice. You know what? When we have a school with one kid with a head lice, what do we do here? We used to shut down the school because it's not acceptable that one child has head lice. The World Health Organization is telling us that it is okay for at least 20% of people, children in these countries have worms. That's fine. It means it's under control, 20%. But if your child here has worms, it wouldn't be okay. So even at the political macro level and policy and practice level, we see how disparities are. What is okay in one country is not okay in another. So these 3 worms, and enter my PhD student Gabby, who's working with particularly this one, because it's becoming so stubborn to treatment, not even with the mass drug administration that we're doing, we're seeing a decrease. And it's impacting the health of children, as we will see. So there it comes, the poop emoji. We have children that have intestinal parasites of many kinds. In their guts, these parasites reproduce. They have female and male parasites. And then they mate. They do have sexual reproduction. And that's the end of what they can do in your body. To find another person or child to infect, they have to go out of the body with the stools. So now the stools are not just disgusting, but are also a source, as a biohazard, right? It's a source of infection. So because they don't have toilets, they don't have latrines, they don't have water, really. Some countries try to build a hole where to bury, but it becomes also like it's a lost battle, right? It's like trying to make this campus smoke-free. It's like, how many stages do we have to go until, right? So the same, imagine if we don't know what smoking does to you, cigarettes. So in these countries, like, you have one latrine for 200 people. Are you going there? Not likely, because it's going to be disgusting. So what are you going to do? Go somewhere else. And somewhere else means that thousands and thousands of people are doing that the same. So poor sanitation, outdoor, in some communities, Even animal and human waste is used as sterilizers. But then these eggs in the environment would germinate, they would become infectious again, infect the next person, and go back to the host. So it's a cycle. It's called poverty. Poverty, rooted diseases, but poverty-causing diseases as well. Because if you're sick, you don't go to school, you have diarrhea, then you become poorer and poorer. And so it's a vicious cycle of poverty and ill health. The map of poverty is the map of tropical countries, and the map of neglected tropical diseases is just the one map, right? Why? Well, we can spend all day here talking about imperialism, colonialism, and what happened to countries in the global south, and why are those countries the poorest as opposed to the global north. And there are geopolitical, geographical reasons why, for example, Europe, the transmission of technology has been a lot easier just by the only factor being easier for people to take a train. Imagine now you can just take a train across Europe. Try doing that from Alaska to Sierra del Fuego here. I mean, that will take you generations, right? So transfer of technology and knowledge has also been slower because of topography. And topography is a big issue when you talk about developing countries. People believe beyond that little mountain is 10-hour walk. So there is a scholar that talks about Honduras and healthcare saying Honduras is frustrated by its own topography. So the map, the burden of these infections is greatest, in the maps. You can see little Honduras here, Central America, and it's affecting children. Normally we call children as the WHO standards, everybody under 15, so from 0 to 14 years of age. There comes the guru of NTDs, the neglected tropical diseases, Peter Hotez, and he's like, I have this great idea. Why instead of just a human development index, we create a worm index? And they're just like, no, that sounds horrible. I'm like, yeah, look. So of course he published in PLOS NTDs, and he looks at the development of countries in different countries and the index of their worms. And you can see how the human development index is inversely proportional to how many worms people have. So it's easy to how many worms we have in Canada and how many worms we have, say, in Kenya. So it is a pretty interesting concept that we already have proven in our own work. This is a child in Honduras in one of the places that we work with Gabby and my team. He's getting water before he goes to school. That's one of the houses where it's a house. It's around, like your shed is bigger than this little house. There was a pregnant woman there that we had to give a ride to the health center because she couldn't make it to the health center. She's really pregnant. And then there was a fight between the person that was inside the cabin and in the bed of the pickup because she was last. And the other one has a baby, and this is pregnant, so who should get inside and who should go to the bed of the pickup truck? And I was a Solomonic solution. I said, okay, you're pregnant, you come inside, can you hold the baby? And so the mother of the baby went on the back of the pickup truck. Yes. We avoided a major community conflict right there. So this is what research is when you're working in the field, right? Like you have to negotiate with pigs that are trying to chase you. I mean, it's just all fun. At the same time, it's sad. But people are people, and they're playing, and they're laughing, and they're loving, and they're hating, and they're just being people. Just poor people. And then, we have houses where entire generations live, and it's great for social networking, amazing. They have a lot of social networks, it's great for your health. Not so great when they have to check also their parasites and their diseases. So this is the little country of Honduras. Just fast, you can see the red dots are where we have identified populations of children that where more than 50% of those have parasites. So all of the red dots are more than half of the children that we studied had parasites. And then the yellow, and then smaller one and the smaller one. So you see how widespread it is. Some places we don't have data because it's impossible to even get there, like here. It's a jungle. So that's called the jungle of La Mosquitia, and we can't even get there ourselves. So we have seen this before, right? The more development, the fewer worms. So you can see here, human development index category by the town, not even by country, like granular by town. The more developed, they have water, they have latrines, they have electricity, the fewer worms. And then infection versus nutritional values, height for age, weight for age, body mass index. You can see that the more parasites they have, the worse they become. This is like 2 standard deviation of the norm or the reference values. You can see how the more worms, the worse they are. So stunting, being short, has a lot to do with malnutrition in your chronic malnutrition in your first years of life. And it's irreversible. You cannot make somebody stunted unstunted. You can make them gain weight, but not to be unstunted. That is permanent. So busy table, but it shows you here the parasite profile of the populations by age, but also just calling your attention to how many were stunted at the age of 6 to 59, so under 5, 34%. How many over 5 years of age? Almost 28. Kids, 1/3 of those populations are stunted or are underweight or thin. And we still have some obesity already, low, and anemia. So how many had anemia is 34 and 65%. It's like crazy. And then the children are there playing and jumping around, and you know that their potential will never be fulfilled. They're alive, right? The point is, yeah, you can be alive, but you're not well, and you cannot fulfill your potential. The same again on another publication. You can see how we model, we try to tease out the factors that are getting in the way of these children's nutrition and lack of blood. Even in a small community, you can see that the better hygiene they have, the better outcomes they have. So when we start looking at the immunological level, at the level of the immune response of these kids, we start seeing that having parasites is not just a trivial thing of having something in your tummy. Your entire system is affected, and your entire immune system is affected. So you respond less to vaccines, you are less protected for viral infections, all your immune system is polarized to a type of reaction that is protecting against the worms because it's what they see most. But when they got an outbreak of influenza, for example, they are totally unprotected. So not only at the macro level and the nutritional level, but at the most intimate level of immunity, these worms are changing the way this kid responds in general. We try, for example, other ways to detect. So this is Gabi and Feng here in the biotech department. We're trying to find better ways to diagnose, so we don't have to play with the emojis so much, because it's kind of like students are like grossed out all the time. So we're trying to minimize our own contact with the stool samples, but still you need to collect them to see how many people have the parasites. So finally, back to our paper. And the paper, what is it saying? That linking poor hygiene in early childhood to child development. So the clearest explanation of this constant assault into children's systems is leading to chronic inflammation and sustained immune reactions that will eventually lead to a lot of microbial ingestion, to develop environmental enteropathy, like a leaky gut that is going into your body inside, and leading to stunting, anemia, and early child development impairment. Of course, everything else will be impaired at that time. So in other words, constant exposure to pathogens through fecally contaminated environment will have an immune system draining effect that will end up with anemia and inflammation in the most overt signs, and to enteropathy, to stunting and deficient development. So then you go and see pictures of India, and you're like, this is more than just dirty. This is a really big health problem. So there is many places you can visit to get washed. Waterpathogens.org is a great resource if you're interested in. There's entire papers there talking about environment, talking about infectious disease, pollutants, toxicants. So just do visit that place. It's a great resource. Waterpathogens.org. And so environmental contamination is huge with human and animal waste. 2 to 4 billion people lack access to basic sanitation, so 7 out of 10 live in rural areas, which is where we work. In our community, 100% of them lack of latrines or sanitation. So there's a medical mission from Virginia. No, it's not a Christian mission. It's like it's a global health internship. So they go there for a week, and they have money. They raise money to give them latrines, and they only had money for 25 latrines, and we have like 250 houses. So they said, well, what do we do? So they do like a draft, and then 1 latrine for these people and 1 latrine for these people, until somebody thought of asking me, and I'm like, no. We cannot be democratic here. No democracy. Give the 25 latrines to 1 community, because then you will maximize effect, right? So they're like, oh, of course, right? But because we know transmission, right? And you need a certain critical mass for transmission. So many million lack access to basic water resources, and even if governments say that you do have access to water, it's intermittent and it's not safe, right? And a lot of people have to pay for it to the trucks. So ending with India, open defecation versus stunting. You don't need to be a genius to analyze this chart and see the more open defecation exists, the more stunted children are. Of course, compounding with poverty and lack of nutrition is not just one thing. But if there's a single factor that you can tease out, is not having latrines. So sanitation is a thing, and it's part of the Millennium Development Goals. And by 2030, we wish that we will have sanitation steps. Right? So keep in mind that SDGs are huge. Everyone has a goal and indicators and targets with them. It's hard to pick, but if you were to pick environment and sanitation, you know that you underlying working also for health and for equity and for dignity. Because it's only dignified that you have a toilet. Right? And imagine how many girls are abused and attacked when they have to go in the dark to relieve themselves. So there is this amazing, you can read the paper later by San, where it's interlinking all of the SDGs and putting them out there with available water and sanitation goals. It's pretty cool. So whatever you do, you can actually link back to the SDGs and say, yeah, this work is framed into SDGs. So I have the citation here. I think it's saying Or when? I don't. Oh, I plagiarized. I'll let you know. So this is how we ruin our environment, and the environment is making us sick. Now we are going to listen that we have to make the sick people better, and how that works for the environment. So, see, that was a good opening act. Victoria. Okay, let me take the emoji, but I'm sure you also, you could need it.
I could need it.
Yeah.
I was actually just going to start with an anecdote. I had a boss that, my first boss when I was working in healthcare said, healthcare is the only industry in which you can have a budget conversation, the topic of poop comes up. And it's entirely normal within healthcare because it's so important. Even just simply like a really interesting hand hygiene fact. Does anyone know what I mean by hand hygiene? It's cleaning your hands, right? So depending on which year stats you look at, between 40 and 80% of primary care practitioners, so people actually caring for those patients, aren't performing proper hand hygiene. And most of these, so parasites is a huge issue, but we all know about C. diff. That's something, C. difficile, very common knowledge. Maybe a loved one has suffered that. That's a fecal-oral transmission. So that's poop emoji to smiley face emoji. Like that's how that happens. And that's happening within our own healthcare system. So it's a really interesting thing to think about. Anyway, that's kind of aside, but budget and feces always goes together. It does. So thank you for having me here. It was great. Like there's so many, as you're talking, I thought, I should have researched more about that in my presentation, but hopefully you guys will have some great insights to draw and maybe get there yourselves. So we'll first start off by talking about Hamilton Health Sciences. For those of you who don't know, Hamilton Health Sciences is a group of hospitals. We have 15,000 staff. We are the only healthcare provider in Ontario that cares for patients pre-birth, so in utero, or in the womb, and then to the end of life. So we're caring for patients on all stages. We specialize in research. Oops, did I flip twice? No, there we go. We are very focused in research. We have academic partnerships, of course, with McMaster Hospital as well as Mohawk College, and we are the largest employer in Greater Hamilton. Now, if you kind of put us on a map here, we have most of our hospitals there are grouped within the downtown or Hamilton Centrals. We have the Hamilton General, the Juravinski Hospital, McMaster Hospital, St. Peter's. We also have an urgent care center, and then way out in Grimsby, which is in Niagara actually, we have the West Lincoln Hospital. So hospitals in our sizes range from being 450 beds, that's the Hamilton General, which is our trauma care site, to as small as about 63 beds we have funded at the West Lincoln. Doesn't mean that's how many people are there, but we have funded for 63 beds at the West Lincoln Hospital. And that's just a reference to overcrowding in the hospital, which is a real problem. So everything, Hamilton General is acute care, so any trauma, so gunshots, anything kind of as violent as that would go, and severe as that would go to the Hamilton General. You have your children's care and maternal care is done at McMaster. Juravinski, of course, is the main cancer care center. St. Peter's is our long-term care. And West Lincoln is a community-based acute care site. So about my role, you might be interested in this since you guys are students and hopefully want to move beyond being a student at one point. So what I do in my role, I oversee all the waste management processes at all the sites. So I work at all sites. What that means on a day-to-day basis is I do all the education, write all the policies, pay all of the bills for the waste, manage all of our environmental compliance pieces, and make sure people are putting things exactly where they belong. Very, very important piece to managing environmental safety as well. And I also am the project lead for doing all of our environmental sustainability reports. Now, I always frame it environmental sustainability, which I'll talk to you why I do that, talk about why I do that. And from a background, I'm a Brock alumni, so that's pretty cool. Background, I have a BA in English literature, so how do you get here? And then I have a master's in English as well from Brock. I did a post-grad after kind of shaking my head and thinking about what I wanted to do with my life at Niagara College in environmental management and assessment, and that's kind of my segue into where I'm at now. So framing sustainability within a healthcare context. So what does that mean? So we all are familiar with this sort of diagram. Sustainability is that intersection in the center. It's a state in which the demands placed on the environment can be met without reducing the capacity to allow people to live well now and into the future. very basic definition: people, planet, profit, triple bottom line, all of these other things we can use to talk about sustainability, broadly speaking. Now, if we're speaking within a healthcare setting, if you say sustainability in a hospital, it pretty much only means fiscal sustainability. All we're caring about is money. Can we provide care to our patients now and in the future? Are we viable as an organization? So that whole environmental piece is kind of ripped away when we're talking about sustainability, which is why I always tack on that environmental sustainability piece when we're doing the reporting. And I say this too because it comes up. If you Google search sustainability healthcare, you're going to come up with a whole bunch of different queries or search results than you would otherwise. So this is just a definition or an explainer from the Conference Board of Canada. So sustainable health and healthcare is the appropriate balance between the cultural, social, and economic environments designed to meet the health and the healthcare needs of individuals and the population. And that leads to optimal health and healthcare outcomes without compromising the outcomes and ability of future generations to meet their own needs. So again, very similar, but mainly focusing on the health of people and our ability to continue to provide care. So sustainability actually at HHS is one of our pillars. So it's one of our pillars in a strategic plan, but you'll see under the definition here of sustainability, we have, it doesn't talk about the environment at all, right? It talks about the needs of the communities that we serve now and into the future. Now, that doesn't mean that it's not a part of what we do, because of course we're driven by legislative compliance, but the main driver here is the community. It's the people we serve. That's the biggest driver for us. So when Hamilton Health Sciences has been embarking on this big kind of strategic plan journey. What do we look like in 20 years? We call it Our Healthy Future. So what Our Healthy Future looks like was heavily informed by a report that was released, an investigative report that was released in the Hamilton Spectator in 2010 that highlighted the differences in the most and the least prosperous neighborhoods in Hamilton. So Dr. Sanchez was talking about mapping poverty globally. This is mapping poverty in Hamilton. So what this report, and it was done with a lot of research as well with McMaster University, highlighted is that there's a 20-year difference in age of death between these communities, so the poorest in Hamilton and the most prosperous. There's an 89-fold difference in secondary school dropout rates. There's a 6-fold difference in dwelling values between the most and the least prosperous. Right, so these things are kind of, we can kind of assume you're poor, you don't live as long. Dr. Sanchez was talking about that within a developing world context, developing country context. This is happening within Hamilton as well. So what they did is they took that, and this is the map that shows the average age of death. So the red zones here are the zones in which you have the least, you're the lowest life expectancy. Okay, so if we look at it, we see that pop out at the top is the Hamilton downtown core. So that your average life expectancy there is 65. Okay, 65. If you live in Ancaster, Dundas area, which is near McMaster Children's Hospital, average life expectancy 86. So this is happening in our own backyard as well, right? It's really interesting to think about. So they took that information and they really, as an organization, we say, okay, so we really need to tackle healthcare from a population health approach. So we need to care about what's going on. What are all the determinants of health, the social and the economic? And how do those factor into how we're going to care for our community now and into the future? So what we're actually doing as an organization, it's led to this big move where the McMaster Children's Hospital is actually going to be relocated to the downtown core area. So it's going to reside in that downtown core, same property as the Hamilton General. The reason for that is because that is the community that needs that access to the care the most, right? We need to intersect and help those people the most. So, and the McMaster site's actually only leased properly, so it makes sense financially too. But it's interesting. So we're thinking about these things, right? We're thinking about how we provide care in our communities and how that affects how we do our business, right? But if you think about, or I guess we'll talk about this. So this was one of the readings that I provided. So it was this, the Ecological Determinants of Health published by the Canadian Public Health Association. And what they really highlight in that article is that we cannot just talk about the socioeconomic determinants of health without acknowledging that there's a direct connection to the environmental. And that Dr. Sanchez highlighted very well in developing areas, right? But we see it as well in our downtown core, and I'll have a visual for you there. So really, this is a great quote from that article, and I just would like to read it out so we can dwell on it a bit. So critical to the success of those efforts is the understanding that the changes in the Earth's ecological systems are driven principally by our social and economic systems and by the collective values and institutions that support them. So our community, right? How we build our culture. As such, we see that the social and ecological determinants of health intertwine and interact, influence each other, and ultimately the health of the people, communities, and societies. So both connect with each other. The environment informs how you live in the environment, and that in part informs maybe your socioeconomic, your economic situation. Both of those contribute to population health, and it's only through action, public action, can we make any changes. Now this happens too as a hospital. Only by the actions we take as a hospital are we able to reduce the amount of environmental impact we're making and contribute positively to social and economic change. So, largest employer in Hamilton, don't you think we have a social and environmental responsibility to do the right thing? And to do the right thing so that our staff that we have on payroll don't become our very sick patients. They don't meet that 65 average end of life. So we're gonna talk about this map again and actually overlap this with look at it through an environmental lens. So we have this hot zone map, right? So we know that these red areas are where you're most likely, you're gonna have a young average age of death. If we look at that from a satellite view, so this is that Hamilton downtown core, what do you notice about that? Industrial, yeah. And almost an entire lack of green space, right? So this is literally just Google Maps, right? It just names all the different sectors. There we are, Hamilton General, right? So if you live here, average life expectancy 65. Hamilton, the director of population health and prevention at Cancer Care Ontario, says that downtown Hamilton has the highest rate of air pollution in the province, right? And then the Hamilton Harbor, of course, notorious for all of the environmental contamination that's gone on there, is still listed as an area of concern by the Environment Canada. Now, instead, if we look at the area around McMaster, where you're expected to live to 86, what do you notice? It's all green, right? So there's the hospital, we've got Coots Paradise, we've got all this green space, golf course, it's lovely. It's painting a picture of the people who live in that and enjoy that space, right? So what it's saying is to live in this space, and we see it reflected in your life expectancy, is that you're privileged, right? You can see that. It's direct, it's there, it's obvious. So what that really tells us is that human health is completely influenced by environmental and social drivers. You cannot escape that, right? So how does that factor into how we provide care within the hospital, and what do we do? So a main driver is really legislative compliance. So we have to make sure that we have recycling programs, that we are monitoring our carbon footprint and our emissions and reducing, et cetera, et cetera. Really, we're always striving for best practice. So there is a bit of an advantage to be able to say, hey, we're one of Ontario's leading hospitals, which I'll say we're not yet, because I would want a lot of facts and data to support that before I would start toting that. And then the other piece is transparency and performing tracking. And most of them really pushed forward by the goal of being financially sustainable. So if we produce less emissions, we're spending less money to make those emissions. We're saving the hospital money. We can invest that money back into patient care. We can better care for our community. So that's the philosophy behind it. So really, at the center of this is sustainability, is human health, right? It's the same thing, sustainable development. And the goal here is healthy people, healthy environment, and healthy economy. That's kind of the ideal state, perfect world, right? But there's a downside to this. There is an impact to providing care, to providing health care, so direct environmental impact. How do those impacts occur? So it's really simple. The environmental impacts are direct result of the healthcare services that we provide. So let's dig into that a little bit. We'll frame that out. So one of our services, as an example, would be bedside care. So these are a list. You can see all the stakeholders that are involved. It's really quite vast. So from an internal, so that's people in the actual space of that patient care environment. You have everyone from that patient to the clinical staff, to the social workers, to the case managers, to the physicians that's visiting them, to the infection control practitioners. All of those people are involved in that patient care, right? And there are fringe things that all of those groups of people have to do. External stakeholders that are involved in that are your families and visitors. So you go visit your loved one in the hospital. What's usually the first thing you do before you come for a visit? What do you ask your loved one?
What they want you to get.
Yeah, like food or a drink, right? So you bring them their dinner, and the dinner that they were provided goes right in the garbage, right? The other dinner that the hospital provided. So think about that. So all of these, we're all stakeholders in this. Not saying don't bring the food. I'm just saying that is a reality. So we're all involved in this process. So from an environmental impacts point of view, so we have water consumption, wastewater created by providing personal care, food production, cleaning, laundering, all of that kind of stuff. Energy is consumed through all of the diagnostic equipment we have. It's the computers, again, personal care, so lifters, different devices, heating and cooling. Waste generation, again, that food that so innocently went into the garbage because we cannot reserve food that's been in a patient room for very obvious reasons. We have the testing, the treatment, procedures, personal care. We have cleaning. We have got all the infection control parameters that tell us you need to package all this material in sterile wrappers, and all of a sudden we have all these sterile wrappers. Well, how do we deal with all that material? And then, of course, the documentation. For as much as we've gone paperless, and we have not reduced paper consumption at all as a hospital. In fact, it just keeps going up. So it tells me two things. First, I printed something up today because I wasn't sure if I'd have my notes here for me. But I do, so that's good. But other thing, people learn. I don't think we're ever going to go paperless too. And that's also to say that there's not an environmental impact with computers as well. Like we think that there's a huge impact, right? Preaching to the choir here, I'm sure, but you understand. So from the toxins and chemicals, we've got cleaning agents, patient treatments and diagnostics. So you could have radioactivity that the patient's receiving for a diagnostic test, cytotoxics, so that's all your chemotherapy waste, chemicals, lab tests. We've got all of that kind of stuff that happens and goes on in the hospital, all as a result of just providing care to a patient in that room. So if you kind of take this out, and a much more intense service we provide is a surgical procedure. We have very similar stakeholders involved in it. We have more waste that's produced, probably twice as much as in a single day or in a single surgery as what a patient would make in a day during a surgical procedure. But we also have increased energy draws. All the air, and say if this was an OR room, all the air in this room would have to be exchanged 15 times in an hour. So think about the energy draw for that. That's just to meet basic care requirements, to make sure that you're not going to get sick on that operating room table because there's something in the air. That has an energy draw, right? And then the filter, so a waste draw as well. So, and then waste, we have even more surgical devices and packaging. Staples, so those big staple guns, those are single use. Single use. They're this long. I'll show you a picture of them later. Single use. So from an energy point of view, I'm going to explore energy and waste in more detail just for the sake of time. How am I doing for time, by the way? I'm okay? Because I could talk all day. But so and from an energy point of view, what we have at Hamilton, it's both the Jervin, the General, and Master sites are cogeneration facilities. Does anyone know what those are? So I see a few nods. Did you want to explain it, or did you want me to explain it?
I believe it's the use of natural gas to provide both heating and electricity, at least how you do it at HHS.
That's right, yes. So what that means is it gives us a lot of sovereignty in our energy production because we don't rely on the grid. If, for whatever reason, our cogens fail, we actually have gone through a simulation for that. The grid can't even supply us with enough electricity. So we have to build that back up in, so we're working with the utility companies to make sure we have that. That's how much electricity we draw. So, but because we cogenerate using natural gas actually has a really high carbon footprint, right? So if you look at it when natural gas compared to other energies as they're produced, sits pretty high in comparison to hydro or nuclear, which is where most of our electricity comes from. So because of that, we have we have a lot of sovereignty, we save a lot of money putting those systems in, but it has a huge emissions factor associated with it. So from electricity consumption, we are doing 32 million kilowatt hours a year. So it's probably hard to conceive. I've kind of boiled it down and on another slide. And natural gas, 36 million cubic meters. From an emissions, so this is all of our sites rolling up. Scope 1, so that's what we generate ourselves, 70,000 tons of carbon dioxide equivalent, and then only 1,300 for Scope 2, so that's what we take from elsewhere. Roll that all up into 71,000. And then, or we can say it another way, so that would be the equivalent of 77 million pounds of coal burned, okay, or enough power to power 8,500 homes in a year, 1,500 passenger vehicles driven in a year, or the need to plant 83,000 acres or 84,000 acres of forest in 1 year to sequester the carbon. So it's 5 hospitals. That's what we're doing to provide patient care, to make people healthy. So it's a really interesting thing to wrap your head around, right? I've taken this directly from the greenhouse gas emissions reporting from the ministry's website, and just to scope in where we sit amongst other polluters in Ontario. So Ford Motor Company, they do 81,000. We do 71,000, right? Nova Chemicals, which does, it's a plastics and resins company, they do 70,000. So that's kind of where we're sitting as a healthcare organization. McMaster alone falls as number 113 of the top polluters in Ontario, just McMaster. Am I shocking you?
Oh, yeah. I'm like, what?
It's not all doom and gloom, but so how do we mitigate our energy emissions impact? We cannot stop providing care or reduce the quality of the services we deliver, so how do we do that? Really, the answer from an energy point of view is retrofits. Unless we're doing new builds, which our newest build is a LEED Gold building, which is our prosthetics building across from the Hamilton General. It's a LEED Gold building, that's great. Very hard to retrofit buildings that are 100 years old. Right? So how do we do that? 2 examples here. We'll dig in a little bit more in detail to the LED retrofit. But if you tally the filter project up and the LED project that we did just in 2017, we reduced our kilowatt hours by over 2.5 million, just by doing those 2 things. Now there are, of course, costs associated with these and potential evaluation for risk. So before we approach any of these sustainability initiatives or environmental initiatives, as we kind of frame them, what we really need to do is evaluate it from all the different aspects. So for us, that means not only environmental, social, and economic, but also if there's any impacts to patient care or infection control. And then from there, determine what the risk is. If the risk outweighs the benefits, it's a flat no. If there's too much patient care or infection control risk, it's a flat no, right? So LEDs, it's a pretty straightforward one, right? So from a positives, it's going to reduce our emissions. But negatives, it does create waste. So we still have to deal with that waste, right? Because we've changed all those bulbs out. Yes, they're recycled, but it's still waste. So we have, from a social, actually we've received complaints about this. The LEDs function, they have a different, what's the proper term? Is it resonance in your eyes? Mm-hmm. But anyway, the lumens hit your eyes differently, so it seems it can cause some problems for some individuals. So that's been one of the things that we've had some issues with. That would also be reflected in patient concerns as well, because if we have staff that have that concern expressed, we're going to have patients as well. Economic, of course, the cost of the bulb replacement. We have the labor that's involved to replace those bulbs. We have to factor all of that in. But the benefit of this, when we did the business case and the return on investment, was 1.5 years. So that was worth it for us, right? So we went forward with that. Pretty easy. The result of this project, we converted 7,700 bulbs, reduced just with this project over 1 million kilowatt hours. Now that, when you factor that out, is only 1% of our total volume, our consumption of kilowatt. It's really, again, really interesting to think about that. But we still took the equivalent of 163 passengers vehicles off the road. So one small thing, large organization, pretty big impact. As a whole, 1% is still pretty good. So from a waste point of view, these are all of our waste streams at HHS. I kind of joke I do everything from body parts to food waste. That falls under my portfolio. And I have funny stories associated with all of those. So landfill recycling. Recycling includes the cardboard, also just the blue bins that we have. We've got food waste or organics, chemical hazards, batteries, scrap metal, e-waste, biohazard waste, which is broken into its own categories of sharp, cytotoxic, pharmaceutical, regular biohazardous, anatomical, and then confidential paper waste as well. So we've got all of those waste streams are coming out of the hospital just because of patient care that we provide. What does that volume actually look like? So these are the stats here, but first maybe I'll ask you guys, what do you, unless someone's really quick at math, how many tons do you think Hamilton General, our largest site, produces a day? If you put it into perspective, an elephant is about 5 tons, small elephant, 5 tons. What would you guess? Oh, 20, that's really high. I'm glad it's not. It's non-punitive, the guessing, guys.
10, yeah.
10, so we've got a 10. It's actually 3 tons a day, so almost an elephant worth of waste a day coming out of the Hamilton General site. What that looks like from an operations point of view, so we have a 40-yard compactor, so those are the really big compactors. Those are going at our major sites 3 times a week. That's how frequently they're moving. Hamilton, or West Lincoln is only once a month. St. Peter's is once a week. So just to kind of get an idea wrap your head around the volume. So in waste composition, landfill waste, we do 2,500 tons a year. In food waste, 180, recycling, 1,600 tons, reuse, so there's some, our sharps containers are actually reusable containers, so some other things that fall under that category, which I won't get into too much of the nitty-gritty about, is about 60 tons. And then our biohazardous is 480 tons roughly, or 475. All of that totals up to to about 5,000 tons a year that we produce. So this is a comparison of site-by-site breakdown. So you can see here that obviously Hamilton General, being our largest site, produces the largest amount of waste. West Lincoln, being our smallest amount of site, produces the smallest amount of waste. You'll also see here that our smaller sites really have a low percentage of biohazardous waste, especially in comparison to their landfill waste. St. Peter's is a long-term care site, high amount of landfill. Why do you guys think that is as a long-term care site? Yeah, well,
hate to say that.
Yes, it's actually related to the poop emoji.
Yeah. Oh, okay.
Briefs.
Their furniture.
Briefs. If anyone has a really clever way of recycling briefs, you're in for a lot of money if you can make it work, because we make tons and tons of briefs a year. So yeah, so that's really interesting to think about. All comes back to that poop emoji. Yeah, that's right. So overall, we're diverting 42% of our waste from the landfill. Does anyone know what percentage the Ontario government set as a goal for diversion? Anyone know off the top of their head? I think it was 2025, they were wanting to hit 60% diversion. So we're sitting at 42% diversion, so that's waste diverted from landfill. 52% of it is straight landfill waste. So if we look at this in comparison to other hospitals, what are we doing? Are we good enough? What does that even mean? 42%. It's pretty kind of ethereal number. Our peer hospitals are diverting 38% of their waste from landfill. We're doing 42%. You can see at all of our sites here where we've increased, except for the Brzozowski here, a slight decrease. But we're above our peer group average, except for St. Peter's because of poop emoji. Because of that, it's a really high composition of landfill waste. So really hard for us to tackle that one. So really we're doing okay when you look at it straight percentages. Now that doesn't really give you a true value of what it looks like on kind of that boots on the ground. Like what about, overall percentage you look okay, but when we look at it from like people in the building, how much is each person in the building making in waste? What's our intensity rate? That's really the true number that you want to look at to benchmark and say, am I actually doing better than the other person? Or is it just that I'm making more recycling overall than someone else, and therefore my diversion rate looks better overall? So I haven't reduced that waste, I'm just making more recycling than someone else. So what we look at is the kilograms of waste per inpatient day. So our peer hospitals are at 10 kilos per inpatient day. We're sitting higher than that at 10.77, and these are all 2017 numbers, by the way. And actually in 2018 we're 11, almost 12 kilograms. So our waste per inpatient day just keeps going up and up. despite all of our best efforts, keeps going up and up. Main driver of that is infection control. It's all that packaging that we make and all the packaging that we have there to make people healthy and to keep their environmental conditions within the hospital sanitary. So to put that into perspective for you, this is what 10 kilograms of recycling looks like, and this is what 10 kilograms of landfill waste looks like. So of course that 10 kilograms of waste per inpatient day is all of the waste types rolled up into one number, but that's just a good point of view for you to look at. So that for every day you are you have your bum in a bed in the hospital, you're making that much waste. So just as a visual point of reference, 10 kilos. So how do we mitigate our waste production? Again, we cannot stop providing care or reduce the quality of services, so how do we do that? This is one of those staplers that I was talking about. This is my colleague, Jen. Okay, so really first basic principles of waste management: reduce, reuse, recycle. And we can only do those where we have the ability or the possibility to do those, because we can't do it everywhere. And then the key thing is you get people to behave. Waste is managing waste downstream, so managing waste as it's already made, it's an item in your hand there, is all about behavior. You have to change how people behave in order to manage that. And of course, manage your risk that's associated with your different environmental programs. So this is a highlight of two of the programs we put in 2017. So we put in an OR recycling program. In a month, between all of our sites, we produce 7 metric tons of recycling. So that's a big elephant in a month, just out of our OR. From our nutrition services, we do 10 metric tons just out of nutrition services. So it's significant. If you look at it, this is kind of it broken out, Hamilton General here, broken out on a month-by-month basis. You can see in June there, that's when we started the nutrition services recycling program. We immediately saw a jump of 2 tons in our volume stats, and then when we started the OR in August, we saw it jump again another 3 tons. So it bears out in the data when you see it too, and it's really neat to know that you've camped yourself in nutrition services for an entire month, but this is kind of the result of that. It's really neat to see. Now, before we implemented these initiatives, we had to make sure, again, just like the energy initiatives, we evaluate the full scope of the impact. And we did this from I'll dig into this from a OR point of view. So we're evaluating, again, environmental, social, economic, impact of patient care, infection control, and then what is the risk. So environmental, we positive, because we're going to reduce the waste that we're sending to the landfill. Negative, we have the potential for contamination in the recycling stream. So we're recycling out of the ORs, that's the goal. Potential for loads rejected by hauler. This one's a huge risk for me, because if this happens too much, the hauler will just turn around and tell me, I'm not taking your recycling anymore. Boom, there's my whole program gone. Right? So you really, really, really have to manage this risk and be really careful about it. Social, we need to improve, it will improve staff morale, and it's going to improve our public image. And then, but there is the negative, the downside of there is an added labor impact to it, right? Because you're going to have to be sorting that much more. It's not all going to one bin. Economic, we have a tiny increase to our recycling budget as a result. The impact to patient care and infection control. So potential for an occupational hazard that's caused either to the hauler or the processor if the recycling is contaminated. So again, going back to poop emoji, we started an entire program to recycle patient care basins, so like K basins, wash basins, different things like that. So we went from a reprocessable item to a single-use item. The reason we did that was because of infection control, because even when those reprocessable stainless steel items, you think in a perfect world, you just throw them in the high heat and it's going to kill any bacteria. Well, in reality, what happens is there's so much pitting on those, there's ridges in those, the bacteria was all hiding in there, and then it was making the patient sick, because those weren't cleaned properly, they come back to the patient, now the patient is sick again, right? So what the organization is forced to do is to go to a single-use item, single patient use. So we put a program in place to make sure that we could recycle them. Well, people aren't behaving, they're not following the protocol of cleaning them prior to being discarded. So we're being forced with the potential of canceling that entire program. So we're talking about 5 tons of blueware every year canceled, because what's happening is it's ending up at the processor, they're opening up those bags, and those basins have poop in them. Again, it all comes back to poop. But it is actually a reality, and so that's a risk. So we're not dealing with regular materials in the hospital, right? We're dealing with unique sort of situations, so we can't do everything as much as we want. In a perfect world, if everyone just did the right thing, behaved, and just sorted all their waste, we could make this work. It's really, really hard to control people, and that's the reality, right? So the risk when we're looking at implementing the recycling in the OR, so of course with the contamination, that just leads, generally speaking, to bad PR, right? So news, all of a sudden, Hamilton Spectator says, Hamilton Health Sciences is sending poop emoji in their recycling. Well, that's a whole new story, right? Contamination and recycling leading to injury, so it could be a potential like a hazard, like an infection or transmission of something, or it could be something as simple as a needle accidentally slips into the recycling bin, or a blood bag. I've seen a blood bag in a recycling bin in a patient room. We no longer offer recycling in patients' rooms because the risk is too high, because of all these factors, right? So contamination in the recycling leading to just overall cancellation of our services. So risk is really high, and we know that. So the next question is, how do we control or manage our risk? Well, the only way to do that is to put in operational controls and run little pilots to see if those operational controls work. So an OR is a very, very regimented process. Everyone in that OR has their job. They know what to do. They're not deviating from that task. So what we said is during a scheduled time, during your case setup, you're permitted to recycle. So before that patient is even in that room, before there's even a risk for a needle coming out or blood or anything else coming into that space, you're permitted when you're doing your case setup, so you're opening up all your packages. You can sort at that point. Then the recycling needs to leave the room, and then it will get recycled. Once that patient's in that room and that procedure starts, no more recycling is permitted. That's the only way we can control that risk. We also use color-coded bags for sorting, which sounds like simple, but the risk here is that if you don't teach people how to sort properly and they're still just throwing everything in the blue tin recycling bag, you're just getting more garbage in the recycling stream. So your risk to the hauler is still there. So the blue tin bag doesn't solve all the problems. It's just only when you can control it, it does. So education and engagement. We needed to determine which materials were acceptable by consulting the processor. So we have a lot of really unique materials in the hospital, really unique plastics. Looking at it, an IV bag, you might think, oh, that's recyclable, it's plastic. Or looking at a glove, you might think, oh, that's plastic, that's recyclable. Neither of those are recyclable. One's potentially vinyl or nitrile, the other is the bag, there's PVC. And attached to that IV bag are all these little bits of plastic pieces and parts that no processor will take, because it's all different types of plastic. So all of that, landfill or pharmaceutical or biohazard, depending on what's in it. Nominate champions to take and act as the leads. We've got champions for this in all of our ORs. And then set out the rules, educate, audit, and enforce. This is continual. This is constant thing you have to do with education. And because the market's changed, I'm not sure how much you paid attention to China rejecting all of our recycling, but what that's had the result of is completely changed my recycling program in the OR. So now I have to break it to my staff and say, oh, hey, last year you guys could recycle this, now you can't anymore. Well, I don't understand, and then I have to explain the whole global market recycling crisis. That's kind of the reality of dealing with this. So really, there are tons of continued challenges. The optics of not having good recycling programs on the inpatient unit and in public areas are really way heavy on us. These are really challenging areas to recycle in because we get so much contamination. Inpatient unit, you pretty much aren't going to do it outside of a supply room. Sustainable procurement policies with teeth. So the only way to manage waste is to manage what's coming in upstream. If we don't have good sustainable procurement policies that actually do something, it's one thing to say, oh, we're going to try where possible to procure in an environmentally responsible way. It's a different thing to actually do that. And then also to trace, is there actually going to be an economic impact to us that's going to limit our ability to provide good quality care for our patients, because now we're using our money to buy something that's recyclable or something that maybe has less of a carbon footprint or whatever. So those are sort of the questions that we really have to deal with, right? Again, I highlighted before the changes in the market and really too many cooks in the kitchen with their own rules and assumptions. So the recycling program works at the hospital differently than it works for people at their house. So they don't understand and they want to say, well, I can do this at home, why can't I do it here? They take styrofoam at home, why can't I put styrofoam in the bin at work? Too much styrofoam in our bins contaminates the load. The load gets rejected. It's a really, really hard thing to communicate, right? So in conclusion, we're just at the beginning of this, right? So I don't have a crystal ball, I don't have a magic wand, I don't have any of that. I just have the struggle of managing people and how they handle their waste. But really kind of the key takeaway is I would say that we really need, and this really emphasizes what Anna was saying as well, is we need to take a sector-wide approach to managing the impacts of the environment and health. And that really is integrated with how we exist as a community, right? So recognizing that it's not just about reducing our emissions. It's about making sure that our neighbors are going to live past 65, right? And those are really real things that people still aren't doing a really good job articulating. And so all of these things are connected. They're all really important. How to manage them in a kind of an operationalize them and I guess make them lessen the impact of just providing healthcare is a really challenging thing. So. Anyway, that concludes my presentation. I hope I didn't take too long. Sorry, very bright.
So thank you to both of the presenters today. Victoria provided a really good overview of all the work that she does at Hamilton Health Science and all the complexities that take place. But I do want to let our audience know that this connection actually came through Carrie Beatty and some others from the town of Lincoln and through the Brock Lincoln Living Lab Partnership. So we're very fortunate to have you here today. And at this time, we're going to take questions from the audience for either of our presenters.
I have a question for you.
Sure.
Oh, there's a question there. Oh, yeah.
Yeah. Well, I really don't know how to frame the question. It's just something I've been thinking. So the WASH program, is there really light at the end of the tunnel, especially for these developing countries? Because I understand the reality of what we're talking about. I have been in those communities where you have to go into the bush to do your thing.
Yes.
Yeah.
Yes.
And then, I mean, this is how the children are brought up. And it's really sad that they're in that environment. And then a lot of people come there and offer them these aids that don't really last. Yeah. So what is there light at the end of the tunnel for these people?
I think there is. There's a magnificent program that is called Community-Led Total Sanitation, and this is a group out of India where they go to the community and they empower the community to do their own. They don't go build the trees. They don't go give them nothing. They just go and say, they actually map with little flags all the emojis around the town, and they say, do you want to walk through this one or you want to go through the one that is not, there's no little flag. So there is hope. There's a lot of investment in sanitation. I think that there's a new launch by the United Nations about WASH. So I think that we've been too fixated with technology, right, at the global level. Like vaccines are going to fix everything, and we want a vaccine for everything. But vaccines are great to keep working on them, but we have forgotten basics. So right now we see that big funding agencies are going back to basic of mosquito nets. Like I grew up with mosquito nets, and all of a sudden it's like, no, just use the thing, like it's just better, right? So people moved from a simple thing to more complicated thing. It wasn't sustainable and did a lot of damage. So now we're going back to basics, and I think that there's a lot. In India, there's even video games, and yeah, maybe you don't want to play them, but they are both images. So I think that, there's entire sectors of society interested in decreasing. So you make the case for the intestinal enteropathy. You made the case for immunity. You made the case for big things that interested people, like a little more glorified. If you just talk about stunting and the tiny kids, but if you make it big and you make it more impactful, we as researchers have that duty to make these things, disseminate our research in a way that people understand it. So I do believe that there is. When, I'm not sure, but I'm seeing changes, particularly in the community that we work with.
Yeah. So just a thought, and so I'm going to put this out there, kind of links to both of them. I also see getting ill is a barrier to sustainability, because when you have a certain amount of energy, and when you become ill, it takes away the energy that you have to act more sustainably. and then you link into the healthcare system, so it actually erodes it. So you have this feedback loop.
Yeah.
So if you start at the beginning with basic health and good hygiene, you actually have a much more positive, forward-reaching.
Yeah, that's the focus. The public health approach is the
Yeah.
focus on prevention.
Prevention, yeah, absolutely.
Yeah, but when you frame it, kind of when you map it out in Hamilton, how can you even prevent negative health outcomes when you have such a huge disparity in the in your projected lifespan? It's massive. So how do you intersect with that, right? And make changes there that are really valuable to the people who are living there. And then also, we can't control how much air pollution is coming from those. The industrial sector that's right by us, right? And the reality is, our economy is in large part based out of that sector as well. So we're all, all connected, but it impacts people. Yeah.
So definitely, promotion, health promotion, prevention, that should be. Unfortunately, we have to frame it as how much we will lose or weight gain in terms of dollars. If you don't have a patient, right? You don't make 10 kilograms of waste, meaning that this is, so that could make a big case for the decision makers if we show them how much we will be saving in terms of preventing.
That's interesting because we right up to our CFO, we track the cost per inpatient day for waste. So that's a metric that he wants to see now. Because now we have the data in a place where I can actually do that, where we didn't have it prior, which is nice. But there's lots of really interesting programs. I mean, Niagara EMS with their program that they have where they're paramedics that would just be idling, have standard calls that they make in the community to check in on patients to make sure that they're patients who might have been flagged, and excuse the term, as a frequent flyer, so that someone who goes to the hospital will watch for things that could be prevented. And so instead the paramedics go directly to that house and they care for the patients there, and that's a pilot program at Niagara.
Yeah, they're doing all sorts of, the Ontario Public Health Association, to build on Dr. Sanchez as well, they are starting to frame their messaging more around the amount of money that'll be saved, because you have to always talk, especially with the new government, fiscally, in order for more money to be put into prevention and health promotion, because for every, dollar that's spent on actual acute care, I think it's 7 cents, something along that. Like, that's the disparity between the funding model as well, is spent on prevention and promotion. So, they're doing great work, and yes, the hospital are doing great work about doing a population health approach, and Hamilton Health Sciences has a lot of great community programs, and will continue, speaking with them. That's really their priority as well, to get out there and do a lot of the prevention piece. So you'll start to see those partnerships, because I think people are seeing the value at a local level, at community level, of kind of reducing those disparities, and it's the whole social determinants of health and incorporating all those elements. So yeah, back my days of public health. Yeah. And my Brock grad time.
I'm curious about latex gloves, and I didn't see a statistic on that. Obviously, that's got to be a big.
We don't have because of latex allergies. We're latex free. So as a hospital, there's some staff who have other allergies to other things have special permissions.
So what are
nitrile?
And what do you do with those?
They're garbage, unless they have blood on them, and then
they go landfill.
That's right.
And do you have, what's the volume on? I imagine that would be high.
That's interesting. Yeah. I have some students working on a project because it's something that really it's a hot topic right now in the media. It's just straws. That's all.
Straws.
I would work in the biology and ecology labs here, and they go in the biohazard, and it breaks my heart.
Yeah, the gloves, there's lots of regulations. The gloves can be regular waste, and there's an impact of putting too much waste in biohazardous too, because all of your biohazardous waste is treated and then landfilled, right? Yeah. So it doesn't go to a magical place. So if it's that yellow bag biohazard, it's treated, autoclaved, and then dumped into a landfill that's regulated to accept treated. So it has a double environmental impact. So you could, it's written right into legislation. You can have
I'm sure that I might be communicating that wrong too, depending what lab you're in and what experiment they're conducting. And it goes back to what you were saying about managing people. And you've got, I think within the biology lab I'm in right now, 25 TAs, right? Yeah. So their gloves are everywhere.
Yeah.
And students, right? And then of course you've got students with that.
Yeah,
There's a lot of gloves going.
Instead of
There's a lot of
McMaster.
Yeah, a lot of gloves.
Yeah, we manage the students instead of the research centers.
We ran a biosafety training down in Honduras with some people from Emory, Atlanta, and so we were using, how to don and off your glove properly, and so he was using a lot of new ones, and people were like. So at the end of the session, they were picking them up because they reused them, right? Because they were clean. So they were like, no, you can't throw them in the garbage.
Yeah.
So and you're right. At the lab, we have labs here in my department that we are using a lot of gloves. And so are we doing an environmental sustainability at Rock in terms of like everything?
They do measure waste, and you're right, the gloves would be biohazard most of the time. So they have measurements on each waste stream. I don't know in different labs if they're sorted differently. We would have to look into that.
It depends on what we do. Some are garbage and some are.
Yeah. What's interesting though, as Dr. Sanchez and I were preparing for this, we were talking about water treatment.
Yeah.
How there was filters that were introduced to a community, and then it tasted too much like chlorine.
Yeah.
And my immediate thought was, well, what do they do with the filters after? Right? Because then they have this waste, and then they have to deal with this waste.
Yeah.
It's like this really interesting thing that you think you're solving one problem, which is exactly what we're talking about in the healthcare. You're solving one problem, but you're creating another.
Yeah.
Yeah.
If you ever saw that movie of the Gods Must Be Crazy, that's an amazing movie, which is like one single Coke bottle.
Yeah.
Create like a war.
Yeah.
Yeah,
that's true. Yeah, that's a good movie.
Yeah.
I'm wondering if either of you can speak to how you handle communications when undemocratic decisions are made. So your example of the latrines was great. In the context of Hamilton Health Sciences, just under 2 years ago, the province changed how autism programs are funded to get kids in when they're younger so the treatment can have a greater impact. The CBC immediately came out with an article that got some of those details wrong. And the effect of that was angry parents showing up at HHS in matching T-shirts, all protesting details that they weren't actually fully informed on because they read an article that seemed to be undemocratic to them, but wasn't fully communicated properly. So I'm wondering how either of you handled communications when a group feels as though a decision is slighting them unfairly.
I have a great story about a town that wanted to prohibit pigs roaming around free, right? Because they're nasty, they destroy things, and they carry diseases, and everybody hates them. So, so the mayor said it's forbidden, and everybody infringing the law is going to pay $25 to get the pig out of jail, kind of thing. Okay, so they started, and who has $25 to free, like to bail the pig? So they're like, okay, so we get the pig to have cash, and now the pig is in jail, and we don't have money to bail him out, so you can keep it, right? So, or they started to fight. So this is a problem. They create a big problem in a town where small-scale pig farming is huge for the familial economy. So they have to sort of like leave the ban, and everything went back to normal because nothing was consulted, and they had to. So yeah, the mayor probably resigned after.
Yeah. So from my point of view, I can really only speak to the questions like I get about waste, and I get a whole slew of things. I get people who tell me I don't believe anything you're saying, to there's enough money in the system to pay me to lie to you, like. Okay. Well, all right. So I get that a lot. I get, we're not doing enough. The hospital should take a stand and not use plastic straws. Then again, we have to go through that whole thing. How does this impact patient care? Like, there's a lot of things to think about, right? The hardest thing is say you need to frame it within what we're required to do from a legislative point of view, and really give people the facts, like shoot it to them straight and just say, hey, this is where we're at now. I know this, I see this, I hope you trust me. I have no reason to lie to you. And we can do better, and we're always looking to do better. communication is key. Yeah, and mostly I get complaints. Very rarely do I get "you're doing a great job" from anyone. So, yeah, you get kind of. Yeah, I haven't had one in a while, so now I'll probably get a bunch. But
You've done a great job.
Well, first of all, thank you both. Both of your talks were really great. I have a question about, well, actually two questions. One was about the emissions that you kind of had, the totals. I'm wondering if in the process you consider like the emissions that would happen as a result of the autoclaving and the incinerating process
scope
that
3.
happens.
Yeah, it's scope 3. We haven't gotten that far yet.
Okay.
So we partner with Sustainable Hamilton Burlington. I'm not sure if anyone's familiar with them, but they're a partner that really helps us kind of expand our capacity without getting another FTE, because this whole sustainability piece is an adjunct to what I'm technically paid to do. Asked for by my VP, but still not part of my job technically. In any case, I mean that just to say, the waste stuff is a big job. In any case, so Sustainable Hamilton Burlington, they are working towards building in like an algorithm that you can kind of plug in your waste volumes, and it could, based on where your waste is going to go locally. Right, because your emissions from if your waste is being sent to Michigan, looks different than if my waste is going to Niagara Falls. Yeah. So there's a lot of factors to consider. So we're working with them, and they're trying to build a model so you can plug that stuff in, and based on kind of averages, we can do that. The ministry, I think the EPA, like the American Environmental Protection Agency, I think had a way to calculate that. But it's really hard to calculate the emissions from waste. I'd love to do it, but it's just not been within scope or something we're able to do right now. Yeah.
And then if I can ask a second question. Well, the document that you shared with us, the Addressing Ecological Determinants of Health, I found it a really amazing read, because I found it was very, really talked about like needing to be transformative. And I think like the example of moving the hospital to where the people actually are in most need is quite a transformative decision, which I think is great. I'm just wondering if, like, I'm assuming there was concern in the like potential of moving a hospital to a location that is highly polluted, and like what went into those decisions.
I think it's probably less about the pollution and more about the levels of crime that happen in that area. Like, because then if anyone knows Hamilton downtown core, it's risky. My first day of orientation, we were told if you need a security guard to walk you to your car. It was like a big factor that played into our orientation. So it's not a safe community. So I think most of the concerns were surrounded by that, and also traffic. Like, how do we put this hospital there? Which is why it's a 20-year plan. And I mean, it takes, by the time you fund a hospital and build a hospital, you're looking at 7 to 10 years anyway. So 20 years seems like a long time, but if you're doing it thoughtfully and you're really having to think about the planning of the city as well, then it takes that long. I would say that probably from caring for the patients, the local environment there probably factors less into when you think about the short duration of time, hopefully, that they're spending in the hospital, and factor is probably more relevant to where they live, right? So if they are living in that environment already, then we can't change anything by sending them up to Ancaster for treatment, right? That's not going to make them any healthier because the hospital's in a better physical, like natural environment. But yeah, it's interesting thing. That's very contentious. Yeah, that move. Yeah.
Okay, so I think that's all the time that we have right now, but if anyone's available afterwards, that might be a good opportunity to get some other questions answered. So wow, that was really insightful, both of the presentations. When you don't have a health background, it's easy to kind of forget how your actions might impact not only the environment, but the health of others and even vulnerable populations, and vice versa. So this was definitely motivation to check our actions and also think more holistically about the connectedness of everything. And so I would like to thank both of our presentations. If you could join me in